the key takeaways from me are stress is not psychological. It starts psychological, but it quickly invades multitudes of other systems. P&I may be the one that takes the biggest hit. 2, this hit can occur very early, very early. It can occur as early as when you're not born. 3, it can be permanent. It's like walking in wet cement. After that cement dries, your footsteps are locked in. It's not as bad as I'm telling you. There are things we can do, but we probably need to appreciate that the P&I system is really one of great importance. And I think I've left cash on the table as a mental health professional by not considering the importance of P&I. So I got to know the elements of P&I. So first what I would do is I'll walk you through the P part of it. Let's talk about the limbic system. And limbic system obviously is involved with 2 critical items of functioning, that being thought processing and emotion processing. But who are the members of this? And this beautiful illustration I have here is I got it from the world's single best medical library. Do you have membership to it? It's called google.com. Excellent medical library. Outstanding. But what a beautiful illustration that we may think the prefrontal cortex matters, and it does, but the real support players to it are behind it. The anterior cingulate, let me use the same, let me use this side just for fair balance. This particular cell side that you're seeing, the anterior cingulate cortex, the amygdala, the hippocampus, and the thalamic region, which are not quite under the control of voluntary control, really are the prime members of the limbic system. Wait till I show you a couple of other things. So we thought, didn't we, that the HPA axis starts at H and then goes to P and then goes to A? That's what's called? Not true. You and I were not taught correctly. So watch this. So let's do this. The anterior cingulate cortex, which is where I process emotion, there it is. And then let's look at, let's say hypothalamic region. I want you to really closely follow. In addition to the tasks we were taught, they also get to control the tone of the autonomic nervous system and the tone of the endocrine system. All of a sudden, how I think alters these other systems, which I thought were completely independent and designed to control my physiologic task. All of a sudden, the way I feel, the way I process my emotion, all of a sudden now controls the immune system from way up there. In fact, it doesn't get higher than this. So P&I is not only not a new concept, Mother Nature has used P&I since the evolution of Homo sapiens to not have an independent system. It's a lot like the American system where we have 3 independent control systems, but they're deeply interconnected to each other. We don't let the executive branch be completely independent of the judicial or the legislative. We don't let the legislative to be truly independent. It's just not a good idea. Nature knew it. Nature wrote her own constitutions 1 million years ago and decided all 3 must balance each other out. And look at this. This limbic system, which we initially thought dealt with nothing but emotional processing, now deals with all kinds of things. How you perceive pain, how do you cope, but very importantly, how you deal with inflammation. What's in this for me? Quite simple. What's in it for me is if this system can damage my inflammatory system, then this system, if I manipulate correctly, should be able to help with my excess inflammation. And I shall show that to you in a second. What's the other member of the P&I system? Well, the endocrine system. Let me use the HPA axis. And this is a paper I wrote some years ago, not for psychiatry, but it's become an important one for psychiatry too. I wrote this for diabetologists who were dealing with abnormal glucose control and peripheral neuropathic pain. So they thought it's all below the neck. But you know what? My eyes are up here. And the truth of the matter is the pain may be down there, the glucose control may be here and here. Not true. So this is what I proposed to them. HPA axis, which is controlled way up there, is of importance to them. But what I told them, I think you're about to like this, that this is an incorrect model. This is an incorrect, it's anatomically incorrect, it's physiologically incorrect. So what is the correct model? This is the correct model. Just the way we don't let states in the United States have complete and full freedom over every decision they make. We have, if you will, a central government system with state governments. What we have is the hippocampus. And the reason why hippocampus may be particularly important to psychiatry is this is where we store not memory, but contextual memory, how we look at things, what our belief systems are. And this then gets to decide how high a tone of sympathetic, parasympathetic system I should set. It also gets to decide how much inflammation should I produce and how much anti-inflammation should I produce. And guess what? It gets to decide how much cortisol you produce. Don't you forget the study Sandra showed you, the tear stress test. All they did is told people this is a fake test. They told them it's fake. Yet, asking you to give a talk in front of people who gave you no emotion in 15 minutes elevates your interleukin-6, which is only produced by your macrophages in your blood, to go up by 40–50%. How is that even possible? Unless the way I look at things, unless the way I feel about things, unless that is not the controller of it, it would not be possible. So not only is the link there, it's a very immediate link. You put the foot on the brake on your car, it doesn't wait for a couple of days before it stops the car. It's immediate. See, that's why PNI is so important to us. It's a super fast moving system to control us. And there you are. That's the danger of the hippocampus being abnormal. But the beauty is the hippocampus is highly modifiable by you and me in our patients through medication and non-medication means. Lots of our therapies that we do are actually hippocampally based. More on that to come in a second. Just remember this, if you will please. This has been one of the great learnings of my and Sandra's career. No man or woman is an island. We are not. So you might say, oh yeah, let endocrinology deal with that, and we let cardiology deal with the sympathetic, parasympathetic system, and yeah, I'm a shrink. I'll deal with the limbic system. You're welcome to do that. Problem is nature does not agree with you. She has no agreement with you at all. It is a truly integrative system. You know, we sometimes say we need an integrative system in my hospital, in my clinic. Nature has us beat by millions of years. But don't look at this as a negative. This is a positive. So what if one system is out of whack? The good news is if you exert control over the other two, you can bring this errant system back in control. There are lots of pathways here. We got very lucky. If you guys want to read this paper, just let me know, and Sandra and I can send you this paper. There you are. The arrows really go both ways. This actually worsens our patient, but this is also the pathway to improve our patients. The autonomic nervous system is unnecessarily ignored by you and me as a profession, completely unnecessarily. All our interventions focus on limbic, and they focus on mood, and I think we just unnecessarily stop thinking about sympathetic, parasympathetic system and how to alter it. But let me first tell you why you and I should focus. Let me walk you through this one, if I may. So let's look at both, sympathetic and parasympathetic. Where do they start? None of these systems start peripherally. They very much start in the brainstem. And what controls the brainstem? Automaticity? Partly, but it's very much controlled by the higher centers. By higher centers, I mean thought and emotional processing. But I want you to look where they go. We were trained it goes to the heart. Well, that's true. We were trained it goes to your skin so you can sweat not sweat. That's all true. But I want you to look at how deeply it invades our basic structures. Our liver, our bone. And very importantly, it has receptors on the immune system. Now, where does the immune system live? I'm about to show you thymus and bone marrow, structures that psychiatry was never interested in, are innervated by parasympathetic and sympathetic system. And get to know these cells, folks. If you want to do, and I want to do neuroimmunology, there are 4 cell lines we cannot avoid learning about. The first is macrophages, which are monocytes, but they're macrophages. They're called macro because they look like the rock. They are pumped up. They are very large in size. And you piss them off, I'll show you in a minute what they do. Get to know B cells and T cells. They're lymphocytes. And get to know natural killer cells. They actually have receptors on them for acetylcholine. So if I have a receptor for acetylcholine, what am I listening to? Which system am I listening to? Parasympathetic. That's the main neurotransmitter of the parasympathetic system. And if I have a receptor for norepinephrine on me, which system am I listening to? So there we go. So guess what? Your brain is literally moment to moment deciding, am I braking or am I accelerating? And this is an exceedingly fast-moving system. How long does it take for your heart rate to go up when you get out of bed and you think there's a snake on the floor? Seconds? That's too slow. It's not seconds. It's milliseconds. And did you think, oh, it's time to increase my heart rate so my muscles can... No. This was at very basic level. Now you know why inflammation is so innate to us and so rapidly. There we go. These are the cells we need to get to know. I'll tell you much more about that. Sympathetic, parasympathetic system, think of them as 2 systems that exist in a very uneasy embrace, because one's main job is to push the other one out. But I'm okay with this, because in psychiatric illnesses, one system dominates. Which system do you think dominates, sympathetic or parasympathetic? It is. In fact, people who have depression have a slightly higher body temperature. They also have slightly higher heart rate continuously. They have a higher sympathetic tone. So if I want to treat these patients, what should I do? One of 2 things. Both will work. Decrease the sympathetic tone or jack up the parasympathetic tone. And watch Sandra's data in a second. She will show you interventions that are known to improve parasympathetic tone. So sympathetic nervous system is not just in your and my heart. The primary organ that the sympathetic system goes after in the PNI is actually the bone marrow. And I don't care how old you are. You cannot say, I no longer use my bone marrow to produce cells, because you do, particularly this one, particularly your femur. That's where we still have very active bone marrow, no matter what your age is. And what is sympathetic system doing there? Does it not have enough things to do? Is it so bored it's got to go look for trouble in bone marrow? Well, no, that's not it. Bone marrow is where you create your B lymphocytes. And guess what? The order comes from top. We are at risk. We are at risk. Produce more monocytes. Monocytes crawl out, and then they become macrophages, and then they produce inflammation, which is not a bad thing. Inflammation is not a dirty 7 or 8, 10 letter word. It's not. It's when it is excessive when it becomes a problem. This is my way for us to look at it together. No longer should we assume I'm a man or a woman stuck on an island of limbic system. I'm not. I have gone places. So my stress, when it arrives, stimulus, I actually can get all of these organs, all the way from my thymus to my spleen, to my liver, to my bone marrow. It gets ready for a fight when a fight is not necessary. And that converts this cell, the macrophage, the immune system, to become what's called ramified. Have you ever seen a picture of Durga, the Indian goddess? She's a very irritable woman. She really is. I grew up in Calcutta. We celebrate her once a year. She's the goddess of destruction. But she's pretty chill on most days. Pretty chill. When macrophages are roaming around, they're roaming around looking to see where I can help. But you and I would assume they're looking for pathogens. Is there a virus? Is there a cancer cell? But as Sandra told us from the ADER study, it's also looking, weirdly, it doesn't have a brain, it's looking for emotional trouble. And when it is ready, it'll start firing. And if you give me stress, the IL-6 that went up came out of right that. It took only 15 minutes to stand in front of an audience, and I am measurably inflamed. And I stay inflamed for up to 24 hours with a silly little test. What's the opposite side? And this is where I think we in the mental health field must learn to use parasympathetic tone elevating interventions. We will look at that. And the reason for that is it's the complete opposite of the sympathetic system. It is so strong, it is so powerful that in animal models you put into septic shock on purpose. If you attach a vagal nerve stimulator to an animal model and turn it on, interestingly, even though I gave you a bunch of pathogens and E. coli into your gut, interesting, the body is able to fight off that E. coli infection in an animal model if you stimulate the vagus nerve. And in depression and most psychiatric illnesses, parasympathetic tone is way too low. And when it's too low, the sympathetic tone wins. It's on a teeter-totter. So stay tuned. Sandra and I will show you some of the components of how to elevate parasympathetic tone in our patients. And then finally, the third member of the PNI system, which is immunology, but immunology that matters to you and I, not some geeky, funky stuff, but stuff that matters to us. So there we have Leonardo da Vinci comes to our rescue again. We shall, and again, thank you, Google, for letting me steal. But this is so very accurate. This is so incredibly accurate. If you want to get to know the immune system, get to know the macro players and get to know the micro players. And let me walk you through that. The bone marrow is home to our B cells. Thymus is home to our T cells. And B and T, as I'll show you in a second, they really matter. But macrophages, which come out of our bone marrow, first as monocytes, there's only 1 or 2% of our white cells are monocytes, just 1 or 2. Now, you have a lot of neutrophils in your system, right? Yes, but their lifespan is 1 to 2 days. They literally live for 1 to 2 days before they're cycled out. A monocyte can live for 30 to 40 years, and it carries memory. If you were sexually abused as a child, and heavens forbid you were, you have monocytes in your body that remember that abuse. And where are they living? Not in your blood. That's really interesting. Over 99% of monocytes we humans possess are not peripheral. They wait, and how interesting, they wait in these 2 places. Spleen and my liver, but primarily my spleen. And they can live 30 to 40 years. That's why so many of our patients are traumatized way beyond the trauma. Way beyond that is completely safe. But every time some situation happens, they react innately in a negative way. So I want you to meet these cells. We'll have to get to know these cells. These are not to be ignored. This is a little complex to remember, so I brought you a very nice cartoon to remember. In fact, why don't you look at it like soldiers? This is really useful and highly accurate. Neutrophils are like street cops. They will stop a problem right now without giving it too much thought. Let's ignore eosinophils, basophils, but I want you to look at macrophages. Macrophages are like the riot police. They don't come out until there's trouble. But riot police, as we well know, don't discriminate very much. So that's the problem. But then you got lymphocytes, which are highly specialized snipers. This is a good way to remember it. And these are cells that we've simply not talked about, because that's not our heritage. But we want to be psychoneuroimmunologists. We're going to have to get to know these guys and gals. So let's break it down. Natural killer cells, that's really important. T cells and B cells, but the most important one of them all are the macrophages. We thought the brain was immune privileged, meaning there's your immune system, there's your brain, 2 separate areas. Why should we cross the border? But as you know, borders are not borders. They should not be borders. Look at this one. Actually, the brain has very good access to peripheral immune system of every kind. Cytokines are tiny molecules, folks. Tiny, tiny, tiny molecules. They don't even need a visa. Like if you go to Canada, you got to show your passport or your something or the other. Here's, you got a car, move in. It's that fast. And it takes literally seconds. Sandra demonstrated that to you. Seconds if it's elevated peripherally or centrally for it to cross. But even the cells are cruising around in your cerebrospinal fluid. They have sampled your peripheral environment, or they've sampled their central environment. In other words, there's difference. Look at this. This is how we used to think. Oh, you live there, I live here. Macrophages, when they're irritated, produce inflammatory cytokines. This is you and I stressed. This is microglia. We produce inflammatory cytokines. Guess what? The blood-brain barrier does not stop it at all. So you're welcome to call me peripherally inflamed, or you can say, oh, you are centrally inflamed. My body didn't go to medical school or nursing school. It says I'm inflamed. There is no distinction. That's why rheumatology struggles so much, not with joints, but with the mind. That's why psychiatry struggles so much with the mind, but also the body. We just thought we were different specialties. We're like Bollywood twins separated at birth, only to meet at song number 18, which is how most Bollywood movies are. That is not true. We have always met each other in the middle. So let me summarize this, if I may. This is actually a pretty accurate summarization. Stress. Call it depression, stress, whatever you wish to call it, very quickly goes and leaves your prefrontal cortex, and it very quickly, and I mean in minutes, is able to come knock on the doors of the anterior cingulate cortex, and very quickly, the hippocampus, the amygdala, all the organs that control the PNI system. And I have a cascading event that leads to all kinds of trouble because my cytokine-producing cells, even though they're peripheral, even though they don't have a brain, they actually are carrying the receptors. My brain does. You believe in serotonin being important in depression, right? Guess what? So do macrophages. They have cells. They have receptors on their skin, on their surface, that are listening to the same signal that your and my mind does. No, we have a peripheral brain. Why are cytokines so important? Because we keep talking about cytokines, but we should probably appreciate and ask ourselves this very simple question. Do cytokines cause depression? Or does depression cause cytokines level to rise? And yes, that's how I got through medical school. So of course the answer is yes and yes. It's always C. But in this case, it's actually true. But this shows you the flaw in our thinking. We call it peripheral and central. But when it comes to PNI, that is flat out illogical. I can do things to your body that in seconds causes central negativity, emotion, but we can do things centrally that immediately affects the body, both in positive and negative terms. There are three main reasons that we in psychiatry do need to embrace PNI, but more particularly understanding cytokines. Number one, cytokines have very easy access. It's so easy, there's no passport required. There's actually no ID required either. Two, we talked about this if you came to my glutamate talk yesterday. I told you it's time to let go of neurons as being our central cell of interest. Astrocytes matter tremendously, and astrocytes and microglia probably produce more cytokines in the central nervous system than any other cell line. Can't walk away from it. And third, cytokines can be manipulated in both directions, for the worse and for the better. Sandra and I will show you studies that our medications, if you've chosen wisely, and therapies if chosen wisely, can rather impressively alter the levels of cytokines. So let's look at interventions. I'll talk about pharmacological, and Sandra, will you talk about non-pharmacological after that? Check this out, guys. If you think, oh, yeah, this was an interesting talk, it doesn't matter that much, though. This will disabuse you of that belief. If you have inflammatory conditions, so that could be whatever, stress, obesity, diabetes, whatever, it doesn't matter, whatever you have. If you have just 4, and most patients have bunches of them, if you just have 4, your chances of that depression becoming chronic is elevated by almost 700%. So not only does inflammation appear to cause more trouble, it makes that trouble much more difficult to treat if you're being an excessive traditionalist, which is sticking to old therapies. So where's the path? What the heck do I do? And this is a model that I have created, written about, and at least practically for me it works. It's a good idea to start thinking of our disorders as SEC models. Wait a sec. Just wait a sec before you jump to conclusions. Wait a sec. SEC, sensory, emotional, and cognitive. And how interesting. Each of these can be influenced by both medications and non-medications. Here too, if you wish to read this paper, just let me know and I'll send it to you. What are my options? And here, Sandra said it and I'll repeat it. There are tons of mind-body options available to us, which, by the way, includes medications. There's no reason to believe medications can't be mind-body. Let me present to you a little bit on what's happening here with medications, and Sandra will come talk to you about non-medications. First of all, do our current medications act as anti-inflammatories? And the answer actually is kind of yeah, but kind of no. The problem for us is this. With SSRIs, SNRIs, we actually do see a decrease in IL-4, IL-6, and IL-10, which are pretty bad inflammatory markers. But we do not sadly see changes with CRP or TNF-alpha. So don't think that our current antidepressants are totally useless when it appears, when we're trying to attack the PNI system. We actually do have an effect. It's just not very much. But it is there. In fact, let me show you the world's single largest database look at these antidepressants. You know it. You just prescribed them the day before you came. Prozac, Paxil, et cetera, on average, they do have an anti-inflammatory signal. It's just not very strong or very reliable, nor complete. Therefore, you may want to start embracing some of the other pharmacology, but also some of the other non-pharmacological agents. What about NSAIDs? Watch this. There are, how many studies am I showing you? 1, 2, 3, 4, 5, 6. They're all using Celebrex. 5 out of 6 are positive as an augmentation agent. And essentially, what COX-2s do is alter the functioning of macrophages peripherally. So I'm not at all suggesting, we're not ready for prime time here, but if you have a patient who has a chronic low back pain who says, I feel better when you give me my SSRI, but my orthopedic lady also gives me Celebrex, don't write it off as, oh yeah, it's just the pain that is better. There may actually be a real antidepressant signal to these drugs. Hold on, we're not done. How about direct cytokine inhibitors, TNF-alpha antagonists? Here the data is somewhat limited, and the last study, if you look at it, our own Dr. Charles Rayson did it. The data overall is positive. But back up a little bit. The data is positive for anything that reduces inflammation. Anything. So our goal is to try and find if there's an inflammatory state and if I can do anything about it. This one shocked me, absolutely shocked me. It came out of Oklahoma, came out of Tulsa. They have a wonderful research program that these are bipolar depressed patients. They're already on therapy. Give them their medications, or give them placebo, or give them minocycline. You familiar with minocycline a little bit? It's a tuberculosis medication, but it's also an NMDA antagonist, non-competitive NMDA antagonist. Or give them aspirin, or give them aspirin and minocycline. Look at that. This is radical thinking, but it's actually logical thinking. Go big or go home. Go broad. These days of hyper-limited attacks are very limited. Look at the numbers needed to treat. 4.7. In psychiatry, if it's anything less than 10, we run towards it. Is this ready for prime time? No. There are side effects to minocycline and aspirin, but the proof of concept is a positive one. Finally, let me show you a very recent study. It is so recent that it literally came out 2 or 3 months ago. Here what they did, this is a Texas study, they actually decided what treatment to give them based on their C-reactive protein. If it was more than one or more, then they gave them an SSRI with Wellbutrin. So they went for a broader approach. Remember I said broad may be better? If they had low inflammation, C-reactive protein or 1 or less, they just gave them a serotonin reuptake inhibitor. If you matched it this way, look at that. This one I'm going to point it out to you. Look at that. If you matched it the way I just suggested, in this study, the remission rates went all the way up to 53%. If you didn't match it, they were 30%. Things are going to change. Everybody here, we are going to become psychoneuroimmunologists.